Broadcast is now starting. All attendees are in listen-only mode.
Hi, good afternoon or good morning, everyone, and welcome to our webinar today, Best Practices in Delivering Virtual Cardiac Rehab During COVID-19. I'm Terry McDonald, and I am a member of the Mid-Axiom Consulting Team. We still have people signing on here, so we're going to pause for just about 2 minutes and let people continue to sign in, and then we will proceed with our presentation. Okay, I think we're ready to get started. Thank you again for joining us. We're very pleased to host our new industry partner, Moving Analytics, for this presentation. They're really the only complete solution designed specifically for the virtual cardiac rehab space. Before we get started, I'd like to go over just a few housekeeping items so that you know how to participate in the event today. So what you're seeing is a screenshot example of the interactive control panel and the attendee interface. You should see something that looks like this on your screen in the upper right-hand corner. You're listening in by default on your computer speakers, but if you'd like to join by phone, just select telephone in the audio pane, and the dial-in information will be displayed there for you. We do have handouts for you. The slide deck is in the handout section of the control panel, and also, I believe, a patient recruitment flyer. So you will have the opportunity to submit questions to our presenters, and we welcome and encourage any and all questions. Just type them into the questions pane over in the control panel and send them as you think of them. As you identify them, please go ahead and type them in, and then we'll collect them and address them during the Q&A session at the end of today's presentation. Okay, so I would like now to introduce Ade Adesanya, who is the co-founder and president of Moving Analytics, and Ade will introduce his co-presenters. Ade, good morning.
Morning, Terry. Thank you for the introduction. So hi, everyone. Thank you for joining us today. We really appreciate you taking out the time to learn more about best practices in implementing virtual cardiac rehab. Before we get into the introduction of the speakers, I just want to give you a background about Moving Analytics. So our mission of Moving Analytics is to empower patients to live lives free of cardiovascular disease. And we're doing that through digital programs that really support patients in adopting healthy lifestyles and managing the risk factors. A lot of our work right now is in cardiac rehab, but we also have other programs that are designed to support your entire spectrum of cardiovascular patients, including your heart failure patients and your PAD patients. But today we're going to be talking about cardiac rehab, and I've brought along with me two of our wonderful partners at Kaiser and Stanford who are going to share more about their experience implementing virtual cardiac rehab and the best practices they're seeing. So to get started, I'm going to introduce Dr. Eleanor Levin. She's the clinical professor at Stanford. She's also our chief scientific advisor. And Eleanor, by far, has had the most experience in implementing virtual cardiac rehab. For the last 3 decades, she's been involved in implementing virtual cardiac rehab. So I thought she'd be a great speaker to bring on today. So Eleanor, if you want to say hi and introduce yourself, that would be awesome. Eleanor, you're muted, I think.
Hi, this is Eleanor Levin, and I was at Kaiser Permanente in Northern California for nearly 3 decades, some as chief and chair of the chiefs, but the entire time as the director of our home-based cardiac rehab program at 23 medical centers that was initially licensed from Stanford. When I retired, I came to Stanford half-time to work in the lipid clinic and women's heart health and general cardiology. And I've also become the scientific advisor for moving analytics and brought all of the protocols up to the November 2018 guideline changes. And I've been working closely with ADE across the country to implement home-based cardiac rehab. Thank you.
Thanks, Eleanor. The second presenter we have today is Dr. Gray, who is the medical director of virtual cardiac rehab at Kaiser Permanente in Northwest. So this is in Sunnyside, Oregon. And I've had the pleasure of working with Dr. Gray for the last, I think, 2 years now in implementing virtual cardiac rehab for her population. So I'm excited for her to be on the webinar today and share her own perspective. So Dr. Gray, if you want to introduce yourself to the audience, that would be awesome.
Hi, my name is Dr. Siobhan Gray. I'm the medical director here, as Ade said, for the virtual cardiac rehab program. We've been working with Moving Analytics for our program here, and we've had good outcomes and good results. I'm happy to be invited to speak today.
Awesome. So thank you both for introducing yourself. So, just when we think about why we're here today, we know cardiac rehab works and it's a very powerful service that we can offer patients. The research shows that cardiac rehab is very effective in improving five-year expectancy and reducing, cardiac-related readmissions, in improving patients' quality of life. But the national average participation has been historically low. It's been in the less than 20% range. And with COVID, that's really dealt a blow to that statistic where, most cardiac rehab programs have had to shut down. And so at Moving Analytics, we've been focused on how do we deliver cardiac rehab to patients at home, leveraging all the advances in technology. And so the goal for today's presentation is really to talk about how to do that. But before we get into the presentation, we have a few poll questions so that we have a better sense of the audience and who's in the room, so that we can also tailor this conversation to you. So the first question is just, what are you trying to learn from this webinar today? Is it more about the clinical guidelines and workflows on how to implement a virtual cardiac rehab program? Is it about the technology and how to set one up? Is it about reimbursement, or is there something else you're trying to learn? So if you could answer the poll question, that would be great. So I'm looking at the early results, and it's kind of a tie between the clinical guidelines and the reimbursement. That's very interesting. Okay, so thinking through the outcomes of the poll, 47% of people said they want to learn about the clinical guidelines for virtual cardiac rehab, 4% said they want to learn about technology, and then 47% said they want to learn about reimbursement. So I think we're going to have you covered today. So let's go to the second question, is have you considered implementing a virtual cardiac rehab program at your organization? Answers are coming in. Wow. Okay, so we have the results for that. And the results are that 74% of the participants on the call today said they have considered implementing a virtual cardiac rehab program. So that's amazing. 11% said they haven't, and 15% said they are not sure. So let's go to the third question. Is what's been your biggest barrier today to implementing virtual cardiac rehab? Has it been reimbursement? Has it been staffing? Is it technology, lack of clinical guidelines and procedures, or others? Okay, and so is it coming in? Okay, so just looking at the results of the poll, 67% of the attendees say reimbursement is the biggest barrier. 3% say staffing, 24% say it's lack of clinical guidelines and protocols, and 6% say other. So this is very, very interesting. I think it's very reflective of where we are today as an industry in terms of cardiac rehab reimbursement or virtual cardiac rehab reimbursement being still at the early stages. But I think we're going to talk about a lot of the things around the clinical protocols and the workflows, and we'll also speak to reimbursement also on this presentation. So you're going to be in for a good treat. So let's get into the discussion. So the format for today's webinar is really going to be more of like a Q&A, where I would be asking Dr. Eleanor, Levin, and Dr. Gray just questions, and they're going to respond to them so that we can keep it more of a dialogue. So to get started, and we can start with Dr. Levin, what motivated you decades ago to implement a virtual cardiac rehab program in your organization? Eleanor, you're muted again.
I need to get out the background noise. At the time we implemented, which continues today, Kaiser Permanente covers about 40% of insured members in Northern California, stretching from rural environments in the San Joaquin Valley all the way up toward Northern California and across the Bay Area, with a very diverse population of African Americans, South Asians, Chinese Americans, Vietnamese Americans, Filipinos, all kinds of ethnicities and languages. We never had a bricks and mortar program, and neither has Stanford. And part of that is the difficulty with commuting and the traffic, the bridges, also the very high cost of office buildings. So this was begun by Stanford as a project in 1988 at Kaiser Santa Clara, and which was my home hospital. It was extremely successful, and we had excellent outcomes, such that we regionalized it through the 23 medical centers. And we have had tremendous success over the time, with 30% of Kaiser Permanente members at Kaiser Permanente Northern California having 30% less cardiovascular mortality than the rest of the state of California. That was reported in the year 2000, and it continues, such that because of our prevention programs, primary and secondary, CV causes were second to cancer, not the #1 cause of death.
Thanks, Eleanor. And so, Dr. Gray, in Portland, I'm curious, what motivated you to look into virtual cardiac rehab and implement it for your patients?
Well, as Eleanor had been, talking earlier, we don't have a brick and mortar building ever for our cardiac rehab. We would contract out with local hospitals, again, because of the huge regional area that we cover. And we had poor participation rates that reflect the national averages for center-based programs, for all the reasons that Eleanor's referred to earlier. So I have a case manager who is really passionate about cardiac rehab, and she had been hearing about home-based cardiac rehab for years, and she said, you know, we really need to start offering this to our patients. So we researched a few different programs, and we, you know, visited with Moving Analytics, and we were able to offer cardiac home-based cardiac rehab here because it was simply cheaper than sending people out to a brick and mortar program. So the people who hold the purse strings always like the words less than or cheaper than. And so we started our program up that way, and we have had excellent referral rates and participation rates in our we call it VCR, or virtual cardiac rehab, in my area.
Cool. Well, thanks for sharing that, Dr. Gray. So moving to the next question. So Eleanor, this one's going to be for you in terms of what are the core components of a virtual cardiac rehab program? And I have this slide from Medicare that talks about the core essentials. But I wanted you to kind of share, you know, from your own work, you know, over the years in terms of what makes virtual cardiac rehab work.
Well, I think what we did was we tried to make a comprehensive program, not just an exercise program. Exercise is one component of it. I used to say that there are 4 essential lifestyle changes and 4 essential medications with secondary prevention. And the lifestyle changes include diet, stress management, weight management, smoking cessation, besides exercise. And the medications include beta blockers after an event, ACE or ARB with blood pressure management, antiplatelet therapy, and anti-lipid therapy. So combined with those aspects, several years ago, we updated the program in Northern California to meet the Medicare criteria for cardiac rehab, to have all the components so that it would be CMS compliant, because every health plan must offer a CMS compliant cardiac rehab program. Now, these are the elements then that I took into the Moving Analytics program, which licensed it from Stanford. So it's the original program. So this includes an individualized treatment plan, supervised by a physician and signed every 30 days, an educational curriculum on exercise, diet, nutrition, signs and symptoms of coronary disease, medication adherence, stress management, smoking cessation, behavioral counseling tailored to the patient's needs, a psychosocial assessment. We always included a GAD-7 for anxiety and a PHQ-9 for depression, with appropriate referral to specialists. And we had outcomes measures of the clinical behavioral outcomes pre and post completion.
Thanks, Eleanor. Yeah, you know, I think that we've really tried to, you know, follow all the guidelines from Medicare, except for the delivery mechanism. And to that kind of leads into the next second question is, Dr. Gray, you know, how does cardiac rehab work, you know, at your organization? How does virtual cardiac rehab work when you think about it from a patient experience? You know, if you could share more about just that, you know, the high level workflow of how you implement this in your organization.
So just to kind of take it through from beginning to end, when the referrals are placed, they're all screened by the medical director. And if the patient is considered high risk, such as they had a cardiac arrest without, you know, reversible causes, or say LVAD patients, people on inotropes, higher risk patients are still referred out to center-based programs. But then the other people who are who are able to do virtual cardiac rehab program, they're contacted by our staff. Now with the COVID era, they receive their packets in the mail. There are still a few patients that we have come into the clinic, and we have them do a 6-minute walk test so we can assess their, you know, stability for exercise. Otherwise, they load the app on their phone ahead of time. They get their fitness tracker. If they don't have a blood pressure cuff or scales, they receive those. And then we have an intake visit with them, usually virtually now, but sometimes present, where we have them answer, a lot of questionnaires, do an assessment, and they receive an exercise prescription. And then with their exercise prescription, they get called once a week for 4 weeks by our case managers, and then every other week for month 2 and 3. And during those phone calls, not only is exercise, how they're doing, and their heart rate range and rate of perceived exertion, those things are reviewed, of course. But as Eleanor talked about earlier, we also do cover all the basic curriculum of center-based cardiac rehab, reviewing medications, smoking cessation. We have a social worker on our team for people who have higher psychosocial needs. We make appropriate referrals to other areas for addictions or smoking cessation. And then the patients, of course, then log in to the Moving Analytics app and record their vital signs, their data. There's a chat feature, and I'm sure you'll go into those specifics a little bit more in the talk, but that's our overview of our patients. And I, as well as the referring provider, receive the individual treatment plan at baseline with 30, 60, and 90 days with appropriate adjustments made if indicated.
Awesome. Thank you for sharing that, Dr. Gray. I have a video I was going to play from Dr. Gray's from Dr. Gray's hospital. Since launching the program, they've gotten a lot of press and attention. So I will play this video for you shortly. Let me pull that up. So that's a great video, Dr. Gray, from your patient. So just kind of moving along, and to build on that, I'm curious, Dr. Gray, if you could share more of like what outcomes are you seeing or have you seen since launching your virtual cardiac rehab program in your organization?
Yes, so our enrollment rate has increased dramatically. So we were probably enrolling 16 to 20% a few years ago, patients in cardiac rehab, which reflect national trends, and that was not clearly good enough. And we are now enrolling at least 75% of patients into our virtual cardiac rehab program. There are still some patients who choose to do center-based, and that's great for that group of patient as well. We also have much higher completion rates. I think that typically people may make 20 to 50% of all of their center-based cardiac rehab visits as 36 visits. That can be quite expensive for some patients. And currently our enrollments rates are about 88%. Our completion rates are 88%, meaning once you start this program, once you're in the flow of it, you tend to stick with it. And it has such few barriers that people do seem to enjoy it. We are still analyzing our data regarding improvements in blood pressure and lipids, but we are showing that it has similar reduction in rehospitalization rates for virtual cardiac rehab compared to the center-based cardiac rehab. So it's just as effective. I can also tell you that I manage a lot of heart failure patients as a member of the Advanced Heart Failure Clinic here. I have seen patients gain a whole level in what we call a 6-minute walk test, a functional class, which is if you had a drug that would improve a patient's functional class by 1 step upwards, that would be worth like $1 million. But here we see it happen with just the cardiac rehab program with many of our heart failure patients. So that's just testimonial to the power of the cardiac rehab in general, and specifically with this program, so it's easier compliance. And you can see here the exercises. They're definitely doing their exercises. It's also about 50% cheaper for us to offer this program. So especially in this day and age where cost is, very important, especially with COVID, that we can still continue to offer this program despite limitations. So it's kind of a no-brainer for our organization.
Thanks for sharing, Dr. Gray. So kind of going to the next segment of questions here, which is going to get into more of the implementation. I think one of the things that is good to know when you think about launching a virtual cardiac rehab program is just what are the key resources that you need to kind of get a program up and running. And from our experience, there's really kind of 4 buckets of things you need. So one is an evidence-based clinical model on how to do virtual cardiac rehab. And I think a lot of organizations today think that home-based cardiac rehab is just calling people over the phone, but there's a lot more that goes into how you deliver cardiac rehab at home so that it's effective in really being able to drive the behavior change that you're trying to make, including exercise and reduction in cholesterol and blood pressure and smoking cessation. So one of the things that you're going to really need as the foundation of your arsenal in virtual cardiac rehab is an evidence-based model that's proven. The second is the technology platform. To streamline the whole delivery of the care, we recommend that you use a technology platform that includes apps for patients, wearable devices, so that you can actually objectively track how patients are doing at home, with the exercises, the blood pressures, the weights. You also need technology from a practice management perspective in terms of how do you schedule your phone calls for the virtual rehab, how you see all the data, how you communicate with the patient. So having a strong, virtual cardiac rehab platform is also important. And then the third thing you have to think about is the clinical staff, right? So staff is very important in driving these programs and the success. I will talk more about that today in terms of what kind of clinical staff you need for virtual cardiac rehab and what their roles are. And then the third is just, training, support, and logistics. For a virtual or telehealth program, there's a lot that goes into kind of like how you, everything from getting patients the devices to set them up in technology, to providing technical support if needed, and clinical training. So you also want to find a partner that can help you with all those 4 things. And those are the things that we can help you with at Moving Analytics. But kind of to speak into each of these components. So for Dr. Levin, one question I have for you is, how did you choose the right clinical model for your program when you started a few years ago?
Well, the program was actually developed at Stanford, and at the time, they did not have any home-based cardiac rehab anywhere. The reasoning that they had is they had a prevention program there called Mr. Fit. And so they made this multi-fit, and they basically were able to decide and prove that post-MI patients could exercise safely at home, which wasn't known at the time. It was felt that this was very high risk. This was pre-angioplasty era. So most people were not completely revascularized. But it turned out that it was extremely successful with improved outcomes rather than reduced outcomes by allowing patients to exercise safely at home. So when we were having such great success in the medical centers in the South Bay of the Bay Area, we got funding from Regional Health Education to regionalize it, provide training programs for all the care managers across the region and for the program directors. So we at each medical center, we would have a program director and 1 or 2 care managers. And we would provide education for them and meetings every year to keep them up to date on the latest lipid guidelines, post-MI medications, etc. So it just was the right thing for us at the right time. And as I said, there are very few bricks and mortar programs in the Bay Area itself, which is the core of Northern California, because of cost and difficulty with long commutes. So the few bricks and mortar programs that they have tend to have a less than 20% enrollment rate and even less than that completion rate. Whereas we had, more than 85% enrollment and, just as much completion rate. Thank you.
Yeah, so Dr. Gray, I'm curious on your perspective on this. When you started to say, okay, we have a problem with cardiac rehab, we want to deliver cardiac rehab virtually, what was that conversation internally, and what was the process to really kind of take a look at the protocols of how do you specifically, deliver this? I'm just curious on your own, what was that process and that conversation internally for you and your team?
Yeah, let me think. Well, I mean, first off, it always helps to have a champion for your program to get it going from the administration level. So we were lucky that we had an administrator who agreed that this program made sense, not only financially, but it was the best thing for the patients. And then after we looked at some different programs, we thought that one case manager per about 300 patients was a reasonable caseload per year. And so we could look at our number of referrals that we sent out to center-based in prior years and adjust our staffing model for that. So we have 2 case managers and we're doing, over about 600 patients a year. So we have the FTE for that. I expanded my FTE as a medical director role. And we have a social worker that is already attached to cardiology. We're quite fortunate to have that. So it was already embedded in our department. So we have her as part of our weekly meetings. And we have a medical assistant who, we hired her as a medical assistant, but she turns out that she could learn technology really fast as well. So she helps with some of the basic technology, but when COVID started up and normally we'd have patients come in and we'd help them put the app on their phone. Not all cardiac patients are technology savvy. But when that changed with COVID, and it's, can take a long time to talk to people over the phone, like click this button here, click that button there. Our partners in Moving Analytics were able to provide us with a lot of technical support to help the patients say right click, left click, or whatever their needs were to get the technology on their phone or on their tablet, and how to get the fitness tracker to link with that. So that's kind of our staffing model that seemed to make the most sense for us. I'm not sure if I answered your question.
So you did definitely, and I guess you can if you were to summarize it, or if I was to summarize that for you, there's really three staff you need to implement a virtual rehab program. So one is a coordinator, like Dr. Gray talked about. This is a person that's more responsible for taking the referrals, contacting the patients, telling them about cardiac rehab as being an option. And when the patients choose to do it, they're more responsible for helping the patients get set up on the technology. And then you have your coaches or your care managers or case managers, people call them different names.
Mhm.
They're mostly like the quarterback of the model. They're the ones that do all the patient treatment plans, the education, the exercise prescriptions, all the remote monitoring. And then you have the medical directors like Dr. Gray that are more responsible for, approving the treatment plans. And Dr. Gray also talked about, the caseloads that you can expect. So we're finding that, it takes one coach or one care manager to manage a panel of 300 patients. And it's about, Dr. How much time do you spend per week as a medical director in delivering this program today for your 600 patients?
I have 2 half days a week to review, to manage the program and all of its details.
Okay.
So we estimate, yeah, so that's the amount of time I have allotted.
Okay, cool. Good to know that. So let's go on into technology, right? So one question I get asked Dr. Gray all the time is that cardiac patients are older, they're the geriatric
Yeah,
patients,
yeah.
and you're seeing, participation rates as high as 75%. So can you talk to what's been the technology experience for your patients, especially with this older demographic? How has this worked for you?
Well, I mean, it's very, it speaks to my own preconceived notions. I thought that we'd only have 50-year-olds signing up for the program. But it turns out that people have family members that can help them load things onto technology. And smartphones are so ubiquitous that you ask a patient, do you have a smartphone? Do you know how to put an app on a smartphone? That a lot of them have the basics of technology. We just had our first online, basically like a Zoom class, education class. And so the youngest person in that class was 65. And they were spending their time remotely to get online for a on-live class. And they moved through the technology. There's always a few glitches, but I've been quite surprised. And we actually have 92-year-olds who have completed the program. You tend to think to yourself that the older patients won't do the programs, but either, we're just being ageist in that way. I do have some patients who don't speak English, who don't read English, but they're still in the program because they have their, perhaps they live with a son or daughter who can help them navigate the technology, putting in their data for them through the app and communicating with the case manager at the same time with the patient. So there's a lot of things that I personally thought were going to be barriers for the program when we started. And I find that those are never the issues. You're always worrying about the things that are never the things you should be worrying about.
Yeah, no, thank you for sharing that. I think I echo everything you just said. I think, as over the years, we found that, now almost 70% of patients have a smartphone, that are eligible for cardiac rehab. And like you said, if they don't have one, either the caregiver or someone in the home, has one and they can support them with the technology. I remember when we started out in the VA, we had to loan patients tablet. And what we're finding was that a few weeks into the program, they'll go buy their own smartphone and they'll give us back the technology because they're like, hey, this is great. And so, yeah, so I think, we found that technology or age is actually not it's not as big of a barrier as you would think in the program.
Yeah.
So one question I have for both of you, and we can start with Dr. Levin, is how do you choose the right patient, right? So when you look at the guidelines that came out last year from the AHA and the ACC around the position paper for cardiac rehab, they stated that virtual cardiac rehab or home base is better suited for the low to moderate risk patients. But we also know that there's no clear-cut guidelines in terms of like what low to moderate risk, right? So can you kind of talk through like your own decision process around how you choose like the right patients who qualify, or how do you choose patients who should be doing this? And we can start with Dr. Levin, and Dr. Gray can answer that as well. Eleanor, you're muted again.
I don't like to have background noise, so I always mute when I'm not speaking.
No worries.
Uh, Basically, we included all patients except problems with, dementia, nursing home patients. The end-stage renal disease patients had their own RN care managers because they were on dialysis or getting close to renal transplant. So those were not included. Heart failure patients, when their EFs were greater than 30%, they were included. Those with very low EFs were in a heart failure or pre-transplant program or an LVAD program. They were not included. But basically, all the other patients could be included. Certainly, somebody who's having ongoing unstable angina needs to have revascularization, but then once they have revascularization, they're included. So it's a pretty inclusive bunch. Someone who had, uncontrolled arrhythmias has a vest, or they're not included. But once they have an ICD and they're stable on medication, they are included.
I see.
So those are the California guidelines.
Yep. Dr. Gray, what's your perspective on that?
Ours are very, very similar to what Dr. Levin mentioned. People on inotropes or LVADs, we don't enroll. We have started doing some heart transplant patients if they can do 360 meters under 6-minute walk test after they've cleared the sternal precautions. People wearing life vests, obviously those people are out. We will take low EF patients if they are clinically stable. That's probably a unique situation for our group, just because I see so much heart failure patients. So we will take low EF patients. You do point out that there are no clear guidelines about what makes a high-risk patient a high-risk patient. So obviously, people who could not be revascularized for whatever reason, those patients we are more nervous about and typically sent to centers. Atrial fibrillation rates that are over 120 at rest, those patients go out. Dialysis patients are difficult because they can be hypotensive. And I have also just kind of a general, catch-all term. If it's not very obvious for like severe aortic stenosis, if patients can walk 10 minutes without an assistive device and can handle technology remotely, those are good people for our program. I try not to take on patients who have chronic O2 because then you're getting into a cardiac pulmonary rehab situation, and that's a little bit beyond our training. But that's pretty much it. Again, not nursing home patients. There are patients that if you need a cane or a walker, we might take those people on. We have them come into the clinic in that situation. We watch them walk. We do their vital signs, and we call it just kind of like a test run. And if they eyeball okay, then we'll still go ahead and enroll those patients.
Well, thank you for sharing that. I think the way we think of it is, one, the inclusion criteria is low to moderate risk, but people who are discharged home, I think that's directly, those are the patients we're really targeting, right? Whose discharge disposition is home. If they're going to skilled care or home care, we wait for them to come back into the home setting before we recruit them. And I think a lot of that is also just physician judgment around, like, is this patient, would they benefit? And I think one of the things that I always think about when we think of low to moderate risk is, obviously there's the exercise component of virtual cardiac rehab, right? But there's the education and some of the other things as well. And so sometimes, we make choices based on, can the patients benefit from the other components of this program at home? If they can use technology around their education and things like that, and not just exercise itself. So those are like different factors. But I think both of you kind of hit the nail on the head in terms of like who we exclude, for sure. And I think the rest of it is just, really looking at the patient and, if they'll really benefit from the program. So one of the things I think you're doing very well, Dr. Gray, in your program is recruiting patients, and you have a greater than 70% participation
Mhm.
rate. So I'm kind of curious if you can share more about like how does recruitment work, and what's that
Right.
process like for you?
Well, we do some things like everybody does. Most people who are discharged from the hospital after bypass surgery or valve surgery, they, as part of their discharge order set, there's a button there for cardiac rehab that's ordered. So some things tend to be automated and built into protocols. After patients have had PCIs, they get a phone call from our nurses in general, and they're offered cardiac rehab at that time, as well as when they are seen by their providers in follow-up. I have done, I call them road shows, where I'll go to different care areas, and I might talk with a care coordinator who works, say, in Salem Hospital, and talk about our program. Uh, I will talk to our hospitalist group and primary care group and talk to them about the benefits of cardiac rehab in general, to try to promote that. People don't really understand its full benefit. And then I also tell them a little bit about our cardiac rehab program. So when they're talking with patients, they know what they're talking. They have some familiarity. I also meet with the PCU and ICU nurses in our hospital at Sunnyside here, and answer questions, as well as meeting with our clinic, vascular surgery clinic as well. So I basically take it upon myself to do a lot of education and try to build it into various protocols when possible.
Yep. And so once you educate those people, I guess, do you know more about their own experience in terms of how they communicate the benefit of the program to the patients? And then how do the patients go from that discharge point to, your coordinators that are going to bring them into that initial assessment?
Well, it's a different course for, CABG patients versus MI patients versus heart failure patients.
Okay.
Um, and so after people cut out of our surgeons like them to start cardiac rehab 6 weeks after they've had their surgery, so they can clear sternal precautions. And so the talking to them right away after they get out of the hospital about cardiac rehab, they're a little bit overwhelmed with everything. So we'll touch base with them, but basically so that we can touch base with them again closer to the time to enroll them.
Yep.
And we'll review them with that program. I think what happens is you get a positive feedback loop. So you tell, one of my colleagues, oh, this, we're doing this cardiac rehab program. He says, yeah, that's cool. And then the patient comes back and he reevaluates and he's like, oh my gosh, this guy lost 20 pounds. What happened? And he goes, well, I did cardiac rehab. And then I get a phone call from my partner saying, oh, wow, this program really works. I was skeptical. And then the nurses who spend a lot of time educating patients on the phone, perhaps feeling like they don't know how to help our anxious patients, having them referred to cardiac rehab, and then seeing the benefits these patients are getting, and the benefits they can get from our social workers. So I think it's one of those things, you start going, then you try to circle back with those people you've talked about and keep getting feedback from everybody. You don't know what is missing in your program until you hear from people. And then you can also hear what people are really enjoying, and you can emphasize that.
Yeah, no, that's very powerful. I think just that we all want to know that our work is, making a positive impact. And I think
Yeah.
that's kind of what you alluded to. Just, when you think about the broader care team, including the other physicians, who will be referring to cardiac rehab, educating them about the importance of the program, how it works, the benefits, the case managers or the post-discharge, recruitment team. So I think that's one of the best practices really is in just really educating and spending time with all those different stakeholders that are responsible for both the inpatient, phase of a patient's care, but also that transition to home. I'm making sure that everyone is reinforcing this message around, cardiac rehab is important. But after they do that, like you're saying, sharing stories about patient successes, I think that kind of keeps everybody just motivated to keep referring
Yeah.
patients to the program. So
Yeah.
thank you for sharing that. I think we're running up on time. So I have one question for Dr. Levin, and we'll talk about reimbursement very quickly. So Eleanor, one of the things that we get asked a lot is safety, right? Like, these are higher risk patients who, had a major cardiac event, they're going to be going home, how can we be getting into the cardiac rehab at home? So can you talk about like safety in the program, what protocols we have in place today? How do we ensure that patients, can do this safely from home? I don't know, you're muted.
History shows that this is very safe. The patients are educated to call 911 during non-program hours if they have an emergency, but there is an urgent, for the way it was at Kaiser, we actually had an urgent clinical support line. In Northwest, it's 8 a.m. to 6 p.m. In Northern California, it goes till 10 p.m. With a nurse with protocols, scripts and protocols for chest pain. Patients are advised only to exercise during the daytime hours, not during the nighttime bedtime hours. And they can get technical support as needed through the app. But, more than 30 years experience with not only safety, but outstanding outcomes.
Thanks for sharing that, Eleanor. Yeah, I think, it's all about patient education. And I think one of the things that we always stress is, helping patients understand from an exercise perspective, what is safe range of exertion so that they're not overdoing the exercise. Patients get the fitness tracker so that helps them monitor the intensity. But then we have that hotline, right, to the clinical staff where they can always call in. And we also have the ability for patients to report things like alerts based on their symptoms and things like that. So there's a lot of things that we've kind of built into the program that really make sure that patients understand what to do, in terms of from a safety perspective, but also when they run into a bind, when should they call 911 versus when should they, reach out to the clinical team. So thank you for sharing that, Eleanor. So the last thing we'll talk about very quickly is just reimbursement for virtual cardiac rehab. So I think this is one of the thorny issues today in just delivering cardiac rehab virtually is that, so far Medicare has not yet started to pay or reimburse for virtual cardiac rehab. I think with COVID-19, there's been different telehealth waivers and there's been lots of different guidance. And so this a school of thought that thinks, some of the waivers can allow for telehealth billing for cardiac rehab. But I'm actually going to call up Terry McDonald, who is part of the MedAxiom team, to kind of speak more to the Medicare telehealth waivers that could possibly allow for you to bill for tele rehab for Medicare patients. So Terry, are you on the line, and can you speak more to that?
Yeah, hi, I'm on the line. Yeah, unfortunately, we don't have payment directly for virtual cardiac rehab yet. We do have under the PHE, the public health emergency, some waivers under the Hospital Without Walls initiative, wherein you could actually have the site of service as the patient's home. There are a number of requirements around that, and it is only approved for the duration of the PHE. So about another 30 days at this point, unless it is renewed again. So that's what we have really in terms of Medicare payment for cardiac rehab in the patient's home at this point in time.
Thanks, Terry.
You want to talk a little bit about, the commercial or Advantage plans that you guys are working with? And then we have a number of questions that have really started coming in here.
Yeah, so I'll talk about those two things and we'll go into Q&A. So I think what we're finding with our work in moving analytics is that although Medicare is not paying for this yet, many of the commercial and Medicare Advantage plans are starting to pay for virtual cardiac rehab. Right now, we're working with about 17 different plans, and they all have, they're all working to cover virtual rehab within the next year. And so we're seeing a lot of traction in that space, and we're hoping that, that the data from those deployments will actually convince Medicare to fully pay for virtual cardiac rehab. I think on the Medicare front, something else for you to be aware of is when you think about the model for delivering cardiac rehab through smartphones and technology, there are also other opportunities to bill to get some reimbursement, not for the cardiac rehab component of what you do, but for providing patients with the with the devices that are providing, data and remote monitoring. So there's Medicare remote monitoring reimbursement today, and there's also some reimbursement around transition of care that can subsidize some of this. But those are all designed for the physician fee schedule, not for cardiac rehab. So we're going to skip this poll question, and we're going to get into Q&A just because we're running out of time. So first, thank you for just taking the time to listen to this webinar today, and then we'll get into Q&A.
Yeah, great job, guys. Really great information and great to hear about the experience you guys are having. This has obviously shown its value, and hopefully we're going to see some movement on CMS at some point in the not too distant future. I know ACC has submitted comments for the 2021 physician fee schedule, so we're all kind of staying tuned to what that might bring. And if we do not get to all these questions, we want to be respectful of your time. We will have one of our panel members email answers. But the first one I'll get to here is one attendee says, I see the cellular scale and BP device. Can you describe how the exercise BP weight data are entered into the app? And where does the therapist view that data? Does it go into the medical record?
Yeah, I can take that briefly, and Dr. Gray can comment on it. So the patients, as part of the program, get a kit, and you saw the pictures of the kit earlier in the slides. Those kits automatically send data to the app and to the dashboard for the cardiac rehab team. And so as patients do the exercises, or as they step on the scale or take their blood pressure, it actually transmits data through a 4G or cellular chip. So patients actually don't have to punch the data in. Now, there are patients in the program who already have their own devices that may not be, the ones we provide. Those patients also have the option of entering that data, manually into the app, and that data goes right away to the clinical team. So that's how the data gets transmitted for the program.
Okay, great. And I have a question about traditional cardiac rehab versus ICR, intensive cardiac rehab. Is the program set up for both or just the traditional cardiac rehab?
I think it's both, right? So from our perspective, what we've done is taken all the clinical guidelines for what should make a cardiac rehab program, and what are all the risk factors and behaviors the patient should be doing, and the goal of the program is to support them. So I think it really doesn't matter if the patient is in a traditional ICR program or traditional cardiac rehab, they can all benefit from this model.
Great. So COVID challenge has proven to be a real opportunity and shown us that we can adapt, we can move fast, and we can adapt to these challenges. How do you keep the momentum going and show others that we can deliver cardiac rehab anywhere to anyone at any time? And there's also a question around economic outcomes, and I think that probably those two are kind of related.
Yeah, Dr. Gray or Dr. Levin, how do we keep the momentum for virtual cardiac rehab going? I'm curious on your perspective on that.
Well, I'll tell you my idea to keep the momentum going is, first of all, you want to make sure your program has as many roots in the ground as possible, so that when economic whirlwinds come along and people are looking to get rid of programs, that yours is fully grounded. So our PR department likes anything that says we're innovative or technology. So trying to get your story out into the press or on various publications just within your organization, highlighting the benefits, specifically around the patient story, is very effective. So I think that helps keep momentum going, is that you keep showing like, hey, we are able to move quickly, we are innovative, we are thinking outside the box. Those are words that people like to hear. And economic outcomes, I don't really have any. Kaiser's modeled differently, so I can't really speak to economic outcomes necessarily. I just know it's cheaper for us to offer it to our patients than sending our patients to center-based programs.
Dr. Levin, what's your...
And I think they're, oh, sorry.
No, go with the question. What was it?
I was just going to say, I think that certainly there are a number of economic outcomes that can be measured just related to clinical outcomes, avoidance of future events and rehospitalization, those types of things. But go ahead, Dr. Levin. We have about 1 more minute.
Well, I would say that's why the payers of commercial insurance are interested in paying for virtual cardiac rehab, because the outcomes are so outstanding that they end up with less hospitalizations, less events, less devices. So we're having a lot of traction with commercial payers to pay for virtual cardiac rehab. And it really helps the patients, because the patients have fewer negative outcomes. So therefore, for the country, it's better, because we end up having better economic output with patients not being, having more cardiac events. So in terms of the economics for the practice, I think as more and more commercial payers pay for this, it's going to help those bricks and mortar programs that right now are looking at a 2-year fail rate, because patients are not willing to come to an indoor gym, even if the local organizations and governments permit it, because of their concern about COVID. And from my infectious disease colleagues, we're not going to be getting back to normal until the end of 2022. And by then, many bricks and mortar programs will have failed. So I think for bricks and mortar programs, you need to have this as an adjunct right now, and then you'll find that it grows a tremendous amount of your business, and it'll be more than your bricks and mortar ever was once you get it going. I think this problem with Medicare is going to push through in 2021 as COVID keeps going, and we need to have more telehealth opportunities for patients. They went on Medicare from something like a few, several thousand visits telehealth before COVID to more than millions of visits for telehealth, more than 10 million. So I think that's going to change as well. But the commercial payers are ready to change now because they can see this. And so I think for those of you who manage bricks and mortar facilities, you need a hybrid program to survive. That's what I would say.
Absolutely. That's really, really great insight. So we are out of time. We do have a number of questions left that I will give to the panel presenters, and we will email you answers. Also, we've talked a lot about some commercial plans that are beginning to sign on. If you have an interest in a virtual program, you can contact Ade and his team at the email there in the last slide, and kind of research what's available and what might work for you in your program. This has been very enjoyable, very informative. We very much appreciate you, Dr. Gray, Dr. Levin, and Ade. Great job.
And thank you, Dr. Gray and Dr.
Thank you
for sharing your experience. Have a wonderful rest of your week, everyone. Bye-bye.
Thank you.
Thank you too. Bye.